Hey everyone, welcome back. You guys might remember this started initially as a coronavirus in the brain webinar series. And now as we kind of move through the recovery period of COVID, we decided to change the format a little bit and kind of look to the future. And so we realized that this is an extremely powerful platform. And I spoke with Gautam Mehta, who's one of our guests today, and Jason Sheehan from the Journal of Neuro-oncology. We decided that it would make sense to really highlight some of the really good studies that's coming out for neuro-oncology, both brain tumors and spine tumors. And we really want to keep this informal and patient-oriented, but also provide information and education, and also keep it interactive. Let patients and doctors and residents and medical students and everyone really interact with the authors and ask the relevant questions. And the things we're focusing on are really the ideas. How do the researchers come up with the question they're asking, and really to interpret the results in their mind and in the framework of their practice, and then really explain to us what they see as the relevance of what they've proposed. And so I want to thank our guests. It's a really special day to kind of kick off the new series, the new format. I'll let everyone introduce themselves. My name is Randy D'Amico. I'm a neurosurgeon at Lenox Hill, focusing on brain tumors. Dan, why don't you start?
Sure. My name is Dan Eichberg. I'm one of the University of Miami Neurosurgery residents, and I'm currently doing an infolded brain tumor fellowship with Dr. Ivan and Dr. Komatar at University of Miami.
And you're the first author on this paper, or the second author?
I'm one of the middle authors.
One of the middle authors.
Long D is one of our medical students is the first author.
Okay, great. Mike, why don't you go next?
Sure. My name is Michael Ivan. I'm one of the brain tumor and skull-based specialists here at the University of Miami in the Sylvester Comprehensive Cancer Center. I focus, as I said, on brain tumors and skull-based surgery. And I also have a brain tumor lab that focuses on glioblastoma invasion, and acoustic neuromas, it's a wet lab where we take our brain tumor samples back and develop new novel treatments.
Great. Yeah. And Gautam, why don't you say hi to everyone?
Yeah, hi. I'm Gautam Mehta. I'm a neurosurgeon at the House Clinic in Los Angeles. Also the social media lead for the Journal of Neuro-oncology. So we're really thrilled to participate in this initiative that Dr. D'Amico is putting on. And I think it's really important that we not just get the important research out in print, but also kind of spread the word.
Exactly. Yeah. And, this is going to be, speaking of social media and the platform for the Journal of Neuro-oncology, this is going to be recorded, and the YouTube clips will be available on the new Journal of Neuro-oncology YouTube channel, which we'll post a link to later. It'll take a couple days to get the video actually up there, but stay tuned because we're going to be loading this series up there, weekly. So just to kind of kick off the paper we're talking about, Dan, why don't you introduce it? Why don't you talk to us about what you guys did, the title, what were you thinking to kind of set it up, and how the whole story came about?
Absolutely. So we just have a few slides so we can kind of go over the background that inspired the paper. I can walk us through some of the figures of our paper, and then we can go into some case presentations of applicable cases from our paper.
Oh, fantastic.
So, as most of us know, glioblastoma is the most common and most aggressive brain cancer. 5-year survival is dismal. It's less than 5%. And typically the standard of care is surgical resection followed by radiation and chemotherapy, the STU protocol. However, invariably, these tumors recur. Almost all the recurrence, 95%, is within two centimeters of the resection cavity. And there's numerous reasons for that are being elucidated. Numerous studies have shown that that extent of resection is very important for improving survival. These studies typically find that there's a certain cutoff of extent of resection beyond which really improves survival. The Lacroix study, the Sinai study, and what's more, after you reach this sort of cutoff, there's a dose-dependent relationship between extent of resection and survival. So with the greater your sense of resection, the greater your survival is typically. So we were deciding to focus in a certain subsection of glioblastoma, multifocal glioblastoma, which is associated with a particularly dismal prognosis. Many papers quote about a 6-month survival for multifocal glioblastoma. And typically the common thought with multifocal glioblastoma is that because survival is so dismal, basically you just get a surgical tissue diagnosis and then have the patient go on to chemotherapy and radiation therapy. You don't want to put them through a huge surgery if their prognosis is so poor that you don't want to have their remaining months be spent during recovering from surgery. However, we had noticed that our question was, is multifocal glioblastoma a surgical disease? And if so, which subsection of patients would benefit most from surgery? Typically we were looking at patients that have one dominant lesion, as well as one or more satellite lesions that are, and the way that we define multifocal was non-contiguous contrast enhancement. So two or more lesions that had non-contiguous contrast enhancements.
Yeah, you guys.
So we wanted to compare how patients that underwent a single craniotomy for a section of a dominant enhancing lesion, how their overall survival and progression-free survival compared to that of patients that underwent biopsy alone.
Randy, do you have a question about that?
Yeah, I just wanted to touch base. You guys talk in the paper about multifocal versus multicentric, right? And you kind of change those terms around a little bit. Can you describe what you mean specifically? I know in the paper you looked at multicentric, not multifocal, or was it multifocal?
Yeah, Dan, you could take a stab.
Sure. I mean, so I think there's sort of different people define those terms differently. Some people define multifocal as multifocal being ipsilateral hemisphere and multicentric as involving both hemispheres. And then some people also talk about whether or not the lesions are contiguous with the flare signal or not. So if they're not contiguous with the flare signal, that's multicentric. And if they're contiguous with the flare signal, that's multifocal. So I think, there's sort of a lot of, unanswered questions about how these factors affect survival and prognosis.
Yeah, so we looked at those two things. Obviously, there's many different factors to look at in multifocal glioblastoma. Just in glioblastoma itself, it's hard to look at all of the possible factors. Mutations, age, KPS score, size of lesion, location of lesion are all important, right? And so then you add in another factor of multifocal, and where is that multifocal satellite lesion? Obviously, there's incredible more details to kind of include, and we don't have a large sample size here. So Dan's going to show you where we discuss that part, but it's hard to include every variable.
Sure. Yeah, keep going. Sorry to interrupt. Sure,
absolutely. And I'll go into a little bit of the statistical test that we use in order to reduce some of the bias from those multiple variables and to be able to control for some of those variables. So this is just our table one. We looked at 34 patients, 18 of whom had a biopsy, and 16 of which had a resection of the tumor. Interestingly, some things I wanted to point out: resection patients more commonly had a right-sided lesion, as would be expected, further away from eloquent dominant hemisphere areas. We do talk about a little bit about there is sort of a similarity in both groups of perilesional, which sort of I guess we use this as a synonym for multifocal spread, and versus contralateral, which we use sort of a synonym for multicentric spread. So they both types of spread were present in both biopsy and resection cases. Median tumor size was greater in the resection cohort, which I think is interesting. Despite having a larger tumor burden, we showed that they had longer survival, as I'll show in a few slides. And then mean age, the mean age of the resection patients was 66.5 years compared to 62.8 years in the biopsy group.
So I mean, sorry to interrupt, but the bottom line here is that the two cohorts are fairly similar, right? You're looking at, you're looking retrospectively at data that is similar. You haven't discriminated too much in terms of biopsy versus resection in terms of who you're choosing to operate on or not. The biggest difference is, like you said, what you would expect, mainly right-sided lesions, and maybe surprisingly the size.
Yeah,
Yeah,
I mean, I think that the key point here is again, just like you said, there's not much difference in the age. We're not going to show the mutational graph, but the mutation status was very, very similar in both cohorts. KPS, obviously, in order to do a biopsy or resection, the KPS was very similar.
Mhm.
But this idea of being able to operating or offering operation on somebody where a bulk of the tumor can be approached via one surgical approach. And so if there was a bulk of tumor that was close to each other, may not be touching, but it was large enough to account for at least 60 to 70% of the overall volume, then those are the people that we would then offer surgery. If you have a tumor that's spread out and equally 30% frontal, 30% occipital, and 30% contralateral, then that would probably not be somebody that we would offer a surgical approach to. But
Sure.
if we felt that we could get around 70 percentile is what we kind of looking back at the data was about that. Most of the patients that ended up in the resection cavity were right around 70% or greater extent of resections via one surgical approach. These are not people that were doing, operating on both sides at the same time to get out, lesions on both sides of the head.
Yeah.
Exactly. Patients where their dominant lesion was accessible with one craniotomy, and we estimated that about 70% or more resection was feasible in these patients. So here are some Kaplan-Meier curves here. In the top left, panel A demonstrates overall survival in the raw data. So there's a statistically significant improvement in overall survival for the resection patients. Panel B in the top right showing that there's no statistically significant difference between progression-free survival for both biopsy and resection. C and D is data that underwent an inverse probability of treatment weighting analysis. So basically, there's some selection bias going into which patients get a biopsy versus a resection. So for example, you would expect, for example, that an older patient might get just a biopsy because maybe they have like worse health and you want to offer them a lower surgery. But age can also be an independent risk factor for having a worse overall survival, progression-free survival. So how do you sort of equalize that sampling bias, that selection bias in a relatively small sample size study like ours, where we had 34 patients? So we performed something called an inverse probability of treatment weighting, where we basically weight patients that have a certain like underrepresented characteristic like age, and if there's fewer young people in the biopsy group, for example, then we can count those, we can weigh those patients more so that things sort of even out, and the selection bias of who gets which surgery sort of equalize a little bit. So C and D, as I mentioned, show the data analyzed by that inverse probability of treatment weighting analysis. And we show that despite doing this analysis, we still are able to see significantly improved survival, overall survival for the resection group compared to the biopsy group. And still the biopsy group and the resection group have not a statistically different progression-free survival, as you can see in the bottom right in panel D.
Mm-hmm. We'll
So
come back to that. I've got a few questions about that, but we'll get there.
okay, absolutely. So that inverse probability of treatment weighting took several covariates into account: age, the number of lesions, the volume of the satellite tumor, the non-dominant tumor, type of spread, and the preoperative tumor volume. But then we wanted to look at a few additional covariates. So we on this inverse probability of treatment weighting population, then we performed a Cox regression analysis, and we additionally looked at extensive resection, age, and Avastin use to create these hazard graphs. And what this is showing here is that in panel A on the left side between biopsy and resection, there was no statistically different hazard of death between the two groups, but in B on the right side, we're seeing that there was actually a statistically significant higher risk of progression with biopsy compared to resection. And then finally, so previously we were looking at simply resection versus biopsy. Here we're breaking down the extensive resection a little bit more. although we decided to, surgically pick patients for resection if we thought we could get 70% or more resection, just looking at the data, we thought that there was a more meaningful cutoff at 85% or more resection. So we divided up the resection patients into less than 85% or greater than 85% extensive resection. And here we see that there's a statistically significant improved overall survival for patients that had a greater than 85% extensive resection compared to those with a smaller extensive resection.
That's 85% of total tumor volume or of the lesion resected?
Total tumor burden. So we added the enhancing volume of the dominant lesion plus the satellite lesion or lesions. And no significant difference between progression-free survival for greater than or less than 85% of extended resection. So with that, we're going to talk about some cases, but
let's take a second just because we have some questions. Yeah, we have a question from some of the viewers. So for patients who underwent resection, how did you guys define progression? Was it local progression or was it any part of this multifocal lesion?
It was any part of the multifocal lesion. So we had, and we'll talk about some of these cases, but if the non-operated on satellite lesion progressed, we would still count that as a progression.
Okay.
And I think that's why when you look at the Kaplan-Meier curves, you don't see that significant difference in the progression-free survival, because we're not taking out all the tumor. There's other lesions that are untreated or not resected, right? I mean, they're all getting treatment with radiation and chemotherapy after. But, so you may not see a progression-free survival difference, but if you're taking out 85%, our question is 85% of a multifocal glioblastoma, is that similar to 85% of a single glioblastoma? If you're talking about volume of everything.
Yeah, absolutely. So yeah, I think one key thing here is the improved overall survival is not just a little bit. When temozolomide got approved, people were, this is a great drug, but it really only improved survival by a couple of months. I mean, the overall survival in your guys' study, even though it's 34 patients, a retrospective study, very focused. I mean, what was the median overall survival in your study? Do you remember off the top of your head?
Median overall survival for biopsy was 7 months, and for resection was 16.6 months.
Yeah, I mean, that's a huge increase, right? That's a 100% increase, basically, in terms of survival. So I think it's very fascinating how well people did with this. And I agree. I think the progression-free survival makes a ton of sense, right? They're getting chemotherapy and radiation, but there's still tumor there that was left, and it wasn't resected to the same extreme. So very, very interesting. You want to go through some of these cases?
Yeah, we just have 2 quick cases just to kind of illustrate some of the points. So the first one, so there's a 65-year-old right-handed female who presented with some facial weakness and confusion. Here you could see on the left image, MRI axial T1 with GAD, very heterogeneously enhancing mass. You could say that, maybe even just looking at that right lesion is enough to call it multifocal because there is separation between the enhancement. And even if you squint, you could kind of say that there may be some difference in separation of the flare signal, although it's so close that it would be hard to believe that. Mm-hmm. But you could also see then on the far right image that in the left occipital horn, that was not just choroid enhancing, that was actually enhancement of a separate satellite lesion of tumor. Mm. And so, great example, right? There's no question here that the tumor burden is primarily localized on the right. And if you take that out, and not only would we be helping the mass effect, you get the diagnosis, but the question is do you affect survival? And I think a lot of the data has been grouped together in the past saying that, these patients don't do well. And so, biopsy or not. I mean, what would you guys do in your practice? Would you just biopsy this, or would you resect the right side?
Personally, and I think the way, that I was trained and what we're doing here at Lenox, we would resect. But with, an understanding with the patient, a discussion with the patient that it might not change prognosis overall. Gautam, what about you?
Yeah, I agree. I think this is a very reasonable one for resection, but I think there's still a lot of dogma out there that, if you see a dot of enhancement on the other side, a lot of surgeons would leave this alone.
Yeah. The tricky part here, and I'm sure you guys, you alluded to it with the dominance of the resection being on right-sided lesions, is this is right by the motor strip, right? And you have to be careful and wary to not injure this patient. Because then, like Dan said early on, you spend your recovery, you spend basically the rest of your life recovering from surgery, and that's a bad issue.
Yeah, no, that's an excellent part, Randy, and I think that's a key to any glioblastoma surgery is a management of quality of life. And by no means do you want to risk their quality of life with only offering them a few months more of life if that means they're in a rehab center, right? So we're not going to go into the surgical additions that you do in a surgery like this, but whether or not you do an awake, motor mapping, DTI, tractography, stimulation, cortical, subcortical tracts, all would be key in this case to kind of ensure a safe surgery. So Dan, you want to just go to the next slide? So, this is a patient that we did, actually Dr. Komatar did this case, aggressive right side of resection. Here's the post-op scan here, a good resection here on the right side. Go next. And so what happened then? And I guess that's really the question.
Yeah.
So 2 weeks post-op, you could see the contralateral lesion starting to grow. And that's an issue, right? I mean, when you operate on somebody, when you do a biopsy, I don't know what your guys' practices are, but in our practice, we try to get them onto chemoradiation in a much quicker time point, within a week or 10 days, try to. But with a surgery, we typically say the 3 weeks of waiting time to get that wound to heal, to risk dehiscence and infection, things like that. And so if you do have a satellite lesion, what happens to that satellite lesion during that time point? So in this time period, we did say that there was progression in the contralateral lesion within the first 2 weeks, and therefore this patient was then counted as a progression within a half a month. However, the patient then ended up getting treatment with radiation and IMRT as the STUT protocol, and then did well, and then 28 months post-op eventually ended up having progression of the contralateral side, as you would expect. And they were methylated and IDH1 mutated.
Yeah, it's impressive.
And then the second case is again a similar story. So a large dominant right-sided lesion with just a small budding lesion on the contralateral side. So again, multifocal, multicentric lesion with both hemispheres involved, but a 66-year-old gentleman, a very good KPS score. Otherwise, he presented with a seizure, but otherwise, and some vision issues, but otherwise functionally very, very good. And so obviously there's mass effect here, and surgical approach, you could definitely get at least 80, 90% resection. And so I would argue that here, again, is another case to be as aggressive as you can, despite the fact that there's a contralateral lesion. And so that's what we did. The patient was taken to surgery, large right-sided resection was performed. Post-operatively, the patient did well. Initially, go next slide. So again, another IDH1 wild type. This patient was unmethylated and did well. Actually, the contralateral lesion was stable for 3 months. And then overall survival, patient was actually doing well. We have another scan that was done at 9 months and showing that the resection cavity was actually still well controlled. The contralateral side had grown slightly. The patient unfortunately passed away at 10 months, but it was actually not due to progression of disease at that point in time, because we had an MRI scan literally a week before they unfortunately passed away that showed the disease was fairly stable. So again, I mean, there's different kinds of multifocal disease. I think there's several papers that talk about, if that multifocal lesion is in the basal ganglia, is it in the brainstem, is it in the cerebellum? Obviously, those patients will do worse, just like if you have a single glioblastoma lesion. But if they don't, then I think that there is an argument that there is a selected patient population that would sort of benefit from an aggressive surgical approach where you could get that extent of resection. And so, these patients that may not be getting that option, I mean, I think that we should look at a clinical trial to enroll them to see what are the characteristics. Is it location? Is it genetic mutations? Or what is the most important thing in these multifocal patients for them? And surgical resection may be beneficial to a large component.
Yeah, really great work. I find this really, really fascinating. why do you guys think that debulking works in this case? You've got disease progressing throughout the brain. Why taking out, the 85% there? Why does it change overall survival?
Yeah, I mean, that's a great question. I mean, I think that there's two parts of that question that I think you could talk about. I think one is this debulking. I mean, obviously there's mass effect, there's edema that's going to happen both perioperatively and then while you're going through radiation and chemotherapy that will happen. And so if you have a large lesion, I mean, I think, Dan, our volume was like 60 cc's or I think the average volume is fairly large.
Yeah, 65.
Yeah, so these are not multifocal lesions that are just small ditzels here and there. These are patients that have a large volume of tumor. Mm-hmm. And so by reducing that mass effect, you minimize their deficits and they are able to be more active, participate more in their treatment process and make them eligible for additional trials and whatnot. But I think there's another reason and the effects of surgery are still a little bit unclear, and whether or not that opens up the blood-brain barrier, whether or not that allows the chemotherapy and STU protocol to work better. I mean, these are questions that we don't really understand very well that may be allowing the satellite lesions maybe to have better penetrance. I mean, this is just a hypothesis, but things that we desperately need to look into to understand that in a better way.
Yeah, it's fantastic. Yeah, every good question leads to more questions, I guess, right? Gautam, you want to say something?
Yeah, so I know you mentioned earlier that kind of the general paradigm in dividing these groups had been if there's a single kind of a dominant lesion that was 70% or more, generally those patients got resection. Obviously, with these results, if you look back on this cohort, do you think some of these patients from the biopsy group would have crossed over into the resection group?
Yeah, I mean, that's a great question. And I think as time goes by, our mantra of treating these patients is definitely changing as time goes by, which is why, I mean, this was not a large, this was not like all of our multifocal. This was kind of just the most recent ones that we looked at where we felt like we had some equipoise in decision-making for how we would treat them. But obviously, as we see this more data, we understand that. And then the question is, okay, well, then what is the real cutoff? Is it 85? Is it 70? We have a small component here where we suggest that 85 is an important area. But the question is then what do you do if you have a lesion that you can only get 60% but causing mass effect and two small satellite lesions that add up? We're developing new adjuvant trials all the time, whether it be laser, whether it be gamma knife that you could do after you finish with the STU protocol that may augment and help these patients down the road. But I think just the idea of biopsy and then that you're done with the surgical component of these patients may not be the right signal to send out to the community.
Yeah, and perhaps with laser, for subcortical or otherwise eloquent lesions, maybe that's going to expand the role of cytoreduction or surgery.
Yeah, absolutely. So I guess, Mike, you already alluded to it, but Dan, coming into practice on your own soon, how does this change your practice? All right. How does this alter how you're going to look at these patients? What factors do you look for when you see a multifocal, multicentric GBM that's going to tell you I should do more here?
Well, I think one of the most important things is you have to tailor your treatment plan based on the individual patient characteristics. What is their health status? How old are they? What are their MRI findings? What are their neurological deficits? What is their, KPS, things like that. Yeah, I don't think you can sort of have a blanket mantra of, multifocal GBM equals biopsy only. You have to really take things into consideration. And I think it also depends on your own, your risk profile. You have to take careful understanding of what is the risk profile of the patient, how long are they going to be in the hospital, how long are they going to be recovering at home. So if you can get these patients home relatively quickly with a relatively low surgical risk, that's not going to be necessarily, eating up the remaining months in a rehab center. So I think you have to really have an honest understanding of, where you are as a surgeon and what the patient's unique characteristics are. But I do think that if patients have a dominant lesion, you're able to get out most of it with one, craniotomy, just sort of like what we've done here. it definitely is reasonable to go for a resection for the dominant lesion.
And one last question, and one last statement I'd just like to say is that, being that on the research side of things, being that my lab is really interested in this idea of glioma invasion, and as it migrates away from that enhancing center, I think understanding multifocal glioblastoma will offer up some new answers into understanding that invasion as we get more specimens and kind of look into the differences as to why in some patients you have a single focus of glioblastoma with a small amount of flare. Some patients you have a single focus with a tremendous amount of flare and an extension of the glioblastoma into the hemisphere. And then in other patients you have this multifocal, multicentric spread of disease. Just like there's differences in breast cancer when they're looking at the breast cancer locally versus metastatically and in the brain, they're finding now new markers in those satellite lesions. And so, in the past, without operating on these tumors, it's hard to get that kind of samples in those tissues to kind of understand what the mutational differences may be. But opening up more avenues, if we feel like this is beneficial, will only lead to more discoveries that could maybe help these patients even further.
Absolutely. Guys, I like to limit these to 30 minutes so they're short and snappy, but that was a great talk. I really appreciate all your time. We'll send you the link, obviously, when it's up. And for anyone viewing, it'll be up on the Journal of Neuro-oncology's YouTube channel, which will be undergoing some, housekeeping recently or soon to keep it clean and tidy and brand new. And it'll also be found on the Lenox Hill channel as well. And just because it would seem, silly not to comment on what's been going on outside and whatnot, we're not ignoring that at all. Actually, Lenox Hill is going to do at 7 o'clock tonight. New York City claps every night. The neurosurgery department here and actually all the nursing staff and everyone are going to go outside and take a knee while the city claps. And, they clap for us, we kneel for them. And so, everyone stay safe. Keep doing what you're doing out there. Keep up the great work, Mike and Dan and Gautam, and thanks so much for joining us. We'll see you all.
Yeah, and understate obviously what you said as well. I mean, it's a tough time, and we're actually just had a protest right next to our hospital just now as we were just about to start speaking. But it's a time that we need to bring attention to the differences between us. I do want to just give one last plug also to our symposium, which will be happening on Wednesday nights. It's focused on brain tumors. We have some of the world experts that will be discussing some tough topics with some panelists talking about cases. So please join us with that tomorrow night. Will be Dr. Caldwell talking about skull-base meningiomas. So I look forward to seeing some of you guys there.
Oh, it's fantastic. As a former panelist, it's a great resource. So thanks a lot, guys. Have a great night.
Thanks for having us.
Thanks for having us.
Take care. Take care, Dan.
Cool. Thanks so much for having us.
Later.